Okay, everybody, I would like to begin by welcoming those members of the public and press who are watching the live stream of this meeting via the County Council's website. I would like to, members, you are by now aware of the need to keep your video camera switched on for the duration of the meeting unless any technical issues and you're asked to go microphone only, and please keep your microphone muted except when I invite you to speak. And please click the raise blue hand function if you wish to ask a question or make any comment. There's always a risk we may run into these technical problems. Excuse me. And I would ask for patience if we do. Should this occur, I will declare an adjournment, and once the fault is addressed, we will resume. Can I remind members and officers that all virtual meetings will be recorded, and these recordings will be published upon the Council's website. Members, I'll begin by calling the names of all the members of the committee to establish your present. Please unmute your microphone and confirm your presence. Councillor Connor.
Present.
Councillor Dupre.
Present.
Councillor Hay.
Present.
Councillor Harford.
Present.
Councillor Jones.
Present.
Councillor Netzinger.
Present.
Hi Lucy, nice to.
Sorry to be late.
That's okay, my dear. At least you're here. That's the main thing. Councillor Reynolds.
Present.
Councillor Smith.
Present.
Councillor Van der Ven.
Present.
East Cambridgeshire District Councillor Ambrose Smith.
Present.
South Cambridgeshire District Councillor Harvey.
Present.
Cambridge City Councillor Massey.
Chair, sorry, she's absent. I'm her substitute, Anthony Martinelli from Cambridge City Council.
Okay, Anthony, thank you. James, do we have that?
Yes, Chair.
Okay, thank you. Welcome, Anthony. And Huntingdon District Councillor Wilson, who is substituting for Jill Taverner.
Present.
Thank you. And myself, Councillor Hudson. Okay, go on to item 1, please. Could I ask James to update us on any apologies?
Thank you, Chair. We've received apologies from Councillor Sam Clark from Fenland District Council, Councillor Jill Taverner from Huntingdonshire District Council, substituted by Councillor Sarah Wilson, and Councillor Nikki Massey, substituted by Councillor Anthony Martinelli. That's all.
Thank you, James. Does any member wish to declare any disclosable pecuniary interest or any non-statutory disclosable interest? If you do, could you please raise your blue hand? Councillor Wilson, you raise your hand. Councillor Wilson, you've raised your hand.
Yeah, I have two non-statutory interests. To item 6, I'm an employee of Cambridgeshire Community Services School Immunisation Team, but not directly funded by Public Health. And secondly, my husband is a governor of a Cambridge and Peterborough Foundation Trust, appointed by Cambridgeshire County Council.
Okay, thank you for that. James, do you have those?
Sorry, Councillor Wilson cut out on the second declaration. Could you just repeat that, please?
So my husband is a governor of Cambridge and Peterborough Foundation Trust, the County Council representative.
That's great, thank you.
Thank you. Item 2, minutes of the meeting held on the 9th of July, and we are being asked to approve the minutes of the meeting held on the 9th of July as a correct record. Can I please ask if any member who does not agree with this to please use the raised hand function now? On that basis, there's no hands raised, so we are happy to approve the minutes as written, and I will sign a hard copy when the wonderful day comes. We all go back to the office. Thank you. Item 3, minutes action log. The next item is for noting is the minute action log, which was circulated by email on the 5th of August. Can I please ask the Director of Public Health, Liz Robin, and James from the Democratic Services. If there are any further updates, what has already been included upon the version we have received, please. Liz, James.
I don't have any further updates. It was circulated quite recently, so the updates are included.
Okay, thank you. Has any members any questions they wish to raise on the minute and action log? If you do so, could you please raise your blue hand? Linda, Councillor Harford.
Thank you, Chairman. I just want to ask about minute 306. This action is shown as completed, but we're the authority that's charged with responsibility for public health, and as such, I think we'll never get a better opportunity to capitalise on some of the progress that's been made by some of the street homeless, the underlying problems that they have during the period of COVID. And that minute does tell us what has been done in terms of preparatory actions for the future. I just wondered, is it within our remit to be able to ask for a report on what has been achieved, say in 6 months from now? Because that would surely allow us sight of anything that we might need to include in our budget for the following year.
I think that's a reasonable request, Linda. Liz, could you come back on that, please?
Yes, I think that the question with issues like this is always whether this is the right committee for the report to come to, because some of these issues will cut across committees. But I think that we could certainly look at the public health aspects of this issue and bring a report on that.
Yes.
We might just need some discussion with other committees that also provide support to this group. But I'm confident we could produce something that was useful and that looked at particularly the health of this group and the impact of the measures that have been taken on health and well-being of this group.
Thank you, Liz. That would be great. Perhaps we could put this on the agenda, please, for the next Chair, Vice Chair, Lead Members meeting, and we'll discuss it in more depth, see where we go with it. You happy with that, Linda?
Thank you, Chairman. I am. Thank you, Ms. Robin, Dr. Robin.
Okay, are we any more? No, there's no more raised hands. So we'll take that as read then, please. Thank you for that. I will just add that item from Councillor Harford to the agenda for the next Chair, Vice Chair, Lead Members meeting. Now, going on, members, we have no public questions or petitions, by the way, so I'll move on to the next item. I intend to move 2 items on the agenda and take items 6 and 7 before the late COVID-19 update, as the officers introducing them have other engagements elsewhere. So that being the case, please, I'd like to go with item number 6, the Public Health Grant 2020 to 21 as the next item, which is included as pages 13 to 21 in the published agenda pack. So we've got our very own Val Thomas, who's going to introduce this report. And Val is on a sailing holiday, which is nowhere too warm. She's at Portland Bill, but she is on a boat on holiday. So Val, as always, really, really very special thanks for being here today. And if you'd like to have your report, please. And I'd like to limit this to a maximum 25 minutes to allow Val to weigh anchor. Val, you're on mute.
Apologies. Thank you very much for changing the agenda schedule. That was very helpful. Thank you very much. I think probably this paper about the public health grant is very much welcomed. It's an increase in the grant, which I think probably I haven't seen an increase in the grant since it started. Let's say a substantial increase. And so what the paper lays out is, one is quite a straightforward request for approval of allocating some of the grant to the increased NHS salaries, which in fact is one of the purposes of the increase, and in a sense it's kind of a given. And the second part of the paper is more for discussion. So very briefly in the first part, in terms of the NHS salaries, agenda for change, salaries started to be increased 3 years ago. The first 2 years, those salaries were paid for by the NHS. The relevance to us is that we commission services that have NHS staff who are on agenda for change. So they have had these salary increases, and so for this year, the salary increases, it is expected, and it is included in the grant information, that the funding of those increases would be funded from the grant. The amounts are outlaid there in the paper, and it's a total of around 150k this year. I've had confirmation of the Change Grow Live increase, which will be 12k. I still haven't had a response back from CPFT, but that I'm sure it's a small service. So it's a relatively small amount given the circa 1.6 million increase that we've had. And I suppose the reason why I sort of here this afternoon, as Peter said, I'm on leave, is that it's the question of obesity. It's certainly been on my agenda for a long time and part of my responsibilities for a long time. And COVID has thrown up many questions around obesity and has certainly brought it to the forefront. We have the new national campaign that was launched last week. Our local NHS, the Clinical Commissioning Group, has launched its local campaign, and I think they presented it to different members as well in different fora. And the information that's been circulated quite widely about the poor outcomes associated with people who are obese and who have the virus have certainly focused and concentrated thought around, is this really the time to do something, and a time to be really creative. We've obviously had the obesity and strategy for Cambridgeshire, and we've been working to that. I think it's very much focused on having a system-wide approach. I think it's fairly well known that we're not going to address obesity through working in isolation. It's a complex issue that requires information. It requires the environment in which people live to be looked at, and look at the pressures that are upon our residents in terms of addressing any of their obesity issues, and so on. And I think I've certainly spoken at this committee many times about obesity, but the opportunity now is that there's a lot of support for it, there's a lot of interest at national level, but also in the local system. And I think I haven't asked for anything particular in the paper, but more requests for the Health Committee to give some time to the issue, to, I think I've heard the term blue sky thinking about, well, what could we really do? What would it call upon? Who do we need to work with to achieve this? And I think it's more asking the committee for your support on this and engagement with looking at how we can best take this forward. And of course, there's a third request to have some additional support to do this. We are, I think as a public health team, we are quite stretched at the moment in terms of COVID is still very much ongoing. And this will need some support to give it the energy that it will need to drive it. And the person in my team who would probably do a lot of this will be shortly going on maternity leave. So we do need someone who will drive this agenda. And that was my third request or third recommendation at the beginning of the paper.
Yes, I was muted, I'm sorry. Thank you for raising your blue hands without me asking you to two members. First is Councillor Jones. Linda, please.
Thanks very much. And I mean, this paper is extremely welcome, and not least because it does, for the first time, as Val says, for quite a long time, actually increase the public health grant. And I'm very relieved that Duncan Selby has managed to, I mean, I would have found it extraordinary if the public health grant hadn't been increased, given that this was said a year or so ago, and also in the context of COVID. But it's very good news that it is being increased, because there is such, as Val said, there is such a big public health agenda. I think she's absolutely right to focus on overweight and obesity. And I do feel a little sad that national government has not managed to join up what is its national obesity strategy, which of course has been around in various forms, certainly since 2015, with its active travel interventions. It seems to me extraordinary that the main focus of the national obesity strategy is actually on diet and fast food, and that it doesn't link up with physical activity. Now, what we know from the Cambridgeshire Health Committee is that Val has done that, and the public health team have done that. And the work in Finland has been to link both diet and physical activity, and that's been very important. So I would welcome the notion of extending that work. But I would also remind us of one of the things that was said when we had a deep dive into public health. Two things that were said. One was about being a system leader, and the other one was about working across the county. Now, although Finland is disadvantaged in several health ways, there are other parts of the county that are too. And it is also, if you like, about a sense of proportionality, about tackling health inequalities, but tackling issues across the board as well. So, you know, proportionate universalism is the term that Marmot used. So I would like to see a bold strategy, and I'm sure Val is right that the way forward is to have discussion about this and work on this and so on. I would like to see a bold strategy that works across more of the county. I would also like to see a strategy that does position public health as a system leader. And that seems to me is something that we have talked about in Health Committee before, in terms of the health in all policies approach. Now, you know, if ever there's going to be a health in all policies approach, it's got to be around obesity, because as Val said, you've got to tackle environment, you've got to tackle local streets, you've got to tackle active travel, you've got to tackle a whole range of things which are in other directorates. And if education, highways, environment, sustainability, and so on. So there has to be some way in which some of that can be brought together. And I think this is a really good opportunity to be able to do that. And I welcome the committee being involved in that carrying that discussion forward.
Thank you, Linda. Some really good points, which we will absolutely take forward, and I'm sure you'll be there with us when we do it. Councillor Van der Ven, please. Susan.
Thank you, Chair. And yes, just to say thank you for all of Linda's comments and Val's introduction. And I also, you know, I'm delighted to see this paper and this particular focus on tackling obesity. I only would add just one small comment in the paper under 2.6, the point that lists the government's obesity campaign. In that introductory paragraph, it cites the example of increased cycling activity, which is great, but I think bearing in mind how important the whole active travel agenda is, could we expand that example and include walking and just try to make this as applicable as possible to the general public? In fact, the buzzword active travel, well, it's in there, I guess, somewhere, but yeah, just to expand it a bit would be good, I think.
Absolutely.
Thanks, Susan. Val will expand that and include the walking. Yeah, thank you. Lucy, Councillor Lessinger, please.
Thank you very much. So yes, I also agree with what's been said so far and with the relief at the grant increase. And I'm particularly wanting to support the work in here that's asking for additional capacity for the public health team, who we know have had extraordinary pressure on them over the last few months and are desperately in need of some extra capacity. So very supportive of that. I'm going to spend most of the time talking about the obesity work, which I do think is crucially important and overdue, but I do also have some quite serious concerns about the language that's being used to discuss it at the moment. Living as I do with 3 young people, they are very concerned that the current language and the current stress around obesity and being overweight is actually going to lead to an increase in eating disorders among some groups. And I think we need to be very careful about talking about healthy lifestyles and healthy weights and healthy diets, rather than always focusing on weight loss. Because while weight loss is something that some of us, and I put myself clearly in this category, need to take very seriously, there are other people who have an equally dysfunctional relationship with food in the other direction. And we need to be very careful that we're talking about healthy eating and healthy habits. The other thing that I want to flag up in relation to work on trying to improve dietary habits and exercise habits is how difficult it is to improve your dietary and exercise habits when your mental health isn't good. And the relationship between stress and depression and poor eating habits is really well documented. And I think we need to be thoughtful about including that in our this wider strategy, looking at trying to improve this across the county. And as the document says very seriously, in Fenland, it's clearly an issue in some parts of the county more than others. But it is an issue across the whole county, and it is something that we need to be tackling across a whole range of areas, and mental health support is one of the things that I think will be needed to try and help people to make changes, because it is very difficult to change habits that have been there for a very long time. So I think those were the 2 main points I wanted to make. So I am very supportive of the proposals in here, but please can we be careful about our language, and can we kind of include mental health support in one of the things that's going to be helpful in enabling people to change their habits. Thank you.
Thank you, Lucy. Some real good points. Val, do you want to come back now, or do you want to? I've got 3 more speakers, and now I've closed it now, so there's no more speakers after these 3. Val, do you want to come back now or wait?
I'm happy to, if it's quicker, I'm happy to do it all at the end. I'll just make
that would be best, I think. Okay. Councillor Dupre, Lorna, please.
Thank you. Just a question about 1.4. I couldn't quite understand the wording here. 1.4 is talking about the public health grant and is saying there is a specific grant condition that local authorities have regard to the need to reduce inequalities between the people, which sounded quite messianic, and I wasn't sure quite what it was intended to imply, other than simply to reduce inequalities. Is there a specific meaning there I'm not grasping? And I was going to comment on 2.9 and the whole work on obesity and so on, but Councillor Jones and Councillor Nessinger in particular have done it far better than I ever could, so I won't attempt to add to what they've said.
Thank you, Lorna. Val, I'm sure you'll come back on that. Jeff, Councillor Harvey, please.
Yes, I just wanted to mention, and I haven't had time to research this as I should have done, but I previously went on the NHS diabetes prevention programme, and I got an email through from them yesterday saying that now, whereas previously you had to be referred by your GP, that's no longer the case. So it looks as though nationally they're expanding that programme. And I expect we're already doing this, but we should be promoting that. I thought it was an excellent course.
Absolutely, thank you. We know obesity is a big link with diabetes, particularly type 2 diabetes. Linda, Councillor Harford.
Thank you very much, Chairman. I'll keep it brief because most of what I wanted to say has already been said, but I do want to endorse particularly 2 comments made. The first one was the one made by Councillor Jones about health in all. And I really do believe that we have to look much more carefully at committees, each committee considering health impacts when they're making their decisions, because at the moment I don't think particular attention is paid to that. And I really do feel, just as we're saying everything's got to have, you know, we've got to consider the environment in everything, we equally need to consider health in everything, and we really need to start to press our colleagues on other committees to do that. And then just quickly, the other thing that I absolutely support are the requests for tackling obesity. This is a lifelong handicap for some people and creates all kinds of mental health and inequality consequences. So I love the fact that Val talked, Ms. Thomas talked about the about blue sky thinking, because I do think that it is incredibly important that we think about how we formulate any strategies we have, because I have to say that I don't think that some of the things that the government are proposing are sensible, not whilst there are the income inequalities that there are amongst our populations. So I'd really like to contribute to that blue sky thinking at some time, because I think that's going to be key to any success. Thank you, Chairman.
Thank you, Linda. And we will all contribute to the blue sky thinking. Val, would you like to come back as brief as you can, please?
Yes, I think Councillor Netzinger raised the question about terminology, and I would absolutely agree. And our current strategy, in fact, is called the Healthy Weight Strategy, and it addresses both the whole spectrum of weight, essentially, and the issues that it presents for individuals. And I think the mental health impact cannot be underestimated in any way. I think all the evidence points to, we have to consider that. It's a key issue. And I think if you talk to any clinicians working with the issue, they would immediately point to the mental health dynamic in weight management. So yes, absolutely, I think the terminology is key. And I think that's based on the messages that it gives to people and how they're interpreted, and getting that right from the beginning is really important. And then there was a point made about health inequalities amongst the people. Yes, and that is a direct, taken directly from the public health grant circular that came from DHSC, so or PHE. And that's exactly how it was expressed. So I kept that, and I think it's a very broad way of expressing the thinking. But I think the concept of health inequalities needs to be a factor in how the public health grant is used. I think that's a key message. And I think the discussion that was had earlier, I think the issues that Linda Councillor Jones raised around Fenland and proportionality and so on, again, begs the questions how we interpret that as well. In terms of the diabetes prevention programme, we do work closely, our lifestyle services work closely with the diabetes prevention programme, as let's say that they have a lot of commonalities. And I think what we're always keen to ensure that people get to the right service, which is for their needs. So in a sense, they're both lifestyle services, but DPP has a huge focus on pre-diabetes, people who are just about to move into full type 2 diabetes. But I will say a lot of people do choose to go with the standard lifestyle service, with not our lifestyle service, should I say, the one that we commission, rather than the specialist one. And I think the important thing is that clients, patients have choice, and they go wherever they feel most comfortable. And I think the comments that made about the health impacts of all committees, and I think the thing about obesity being complex, it does call for efforts across all the committees in a sense, because so many of the committees, the measures that evidence tells us that we should be addressing falls within their particular remits. And I would actually like to thank committee for their support on this and all their supportive comments, and also the acknowledgement that the capacity of the public health team has, and I think probably still is, though I think it has improved considerably, being stretched, and to make sure that kind of public health drive behind the obesity agenda is maintained, and the support that can be provided to members. I think that comment and support for additional capacity was very much appreciated. Thank you.
Thank you, Val. And thank you for spending the time from your holiday to come present this really important paper. So as a committee, we've been asked to note the increase in the ring-fence public health grant allocation and approve the following proposals. So proposal A is the allocation of funding to commission services to meet the cost pressures created by any increases in the agenda for change salaries. That's for the NHS people who work for us. And B is to refresh the Cambridgeshire Healthy Weight strategy and allocate funding of support of new actions. And C, to support the allocation of funding for a temporary member of staff to energise and drive the obesity agenda. If anybody is against agreeing those proposals, could you please show your blue hand? I'm glad to see there aren't any. So that was a unanimous vote, really, in favour of the recommendations. So thank you. And Val, weigh anchor and have a lovely holiday. Thank you.
Can I just say something else?
If you must.
In terms of, everyone thinks so. In terms of taking this forward and the committee's involvement, it would be good to have that discussion in terms of how it could be taken forward with yourselves and that blue sky thinking.
Yes, perhaps we could add that too to the next chair, vice chair, lead members meeting.
Thank you.
Yeah, no problem, Val. Have a lovely time. Thank you for your time.
Thank you.
Okay, members, going on to the second item on the agenda, I'm going to move. So we now go to item 7, please. And you will recall at the last meeting that Jan Thomas kindly agreed to provide a written briefing on the main issues included in the response to Stephen's letter. Again, with our agreement, I tend to change the agenda, so I'm allowed to speak, Jan to speak now, because she's a very busy lady. It's on pages 23 to 28 of the main agenda pack. And I would like to, this is going to be limited to maximum 30 minutes, please. So now I welcome Jan once again. There you are, I can see you. Hello, thank you very much, Jan, and it's over to you.
No, thank you very much. And hello, and it's for those that haven't met, I think I know everybody by now, but I'm Jan Thomas. I'm the Accountable Officer of the CCG, and I've been co-chairing the SCG with Gillian through the COVID experience. So we've given you a paper here, and in true style, we've had another letter out since. In that this was this was the first response that we were asked to be put in, and we've since had another letter out on Friday from Sir Simon Stevens with a set of requests for phase 3 of our recovery. So if it's okay, what I'll do is I'll give you just some highlights from the information that we've given, and then just open it up for questions if that's okay, because I'm sure that people have got plenty to ask, and I'll give you a quick briefing on the next set of asks that we've had. So so I was asked to come and talk about how we were going to deal with that recovery and the requirements in one of the Sir Simon Stevens letters. The first thing is to say is that as of last Friday, the NHS was stood down from a level 4, which is national emergency, into a level 3, which is a regional emergency. So on the ground, that means very, very little different to what we were doing at the time that this paper was submitted. But I think it does give us an indication that in dealing with the recovery and the recovery to COVID, it's much more of it's becoming much more of a local issue for us to be able to respond appropriately. But during it, in order to get our initial response right and our recovery right, what we actually do is we have a number of key groups. So we still continue to have something called Health Gold, and that is our way of making sure that we're delivering all of our commitments on an operational basis. And Wendy actually from Peterborough and Cambridge actually joins us on that group to make sure that local authority issues are represented. We also then have set up a number of subgroups to make sure that we are making sure we're prioritising in the right area. One of the most important of those being our joint clinical group, because it's very important that going forward and our recovery plans are based on the level of risk and effectively doing least harm and reducing inequalities for our patients in the coming days, weeks and months. So you can see in the table that we have actually been restarting services, and we also are checking in with our clinicians a lot about the important services that we are providing. And I do want to say, just to make it absolutely clear, that our cancer services did continue through this. And actually the ramping up of services now is happening at quite a strong pace. So where you can see in the paper that we highlighted here, cardiovascular, respiratory and mental health, particularly in children, but also some adults, that is on the assumption that because we hadn't stood down the cancer services in the first place. So I don't want people thinking that we have missed that out. So fundamentally, the phases that we were asked to work with in the Simon's letter means that now we are officially in phase 3, and phase 3 of that is really to ramp up as many services as possible. And the way that you will see in the paper that we're thinking about this is that we think we've got a small window. We always prepare rigorously for winter every year. This year that is going to be more critical than ever, including, and I'm sure Liz will join me in pushing this, including flu vaccination programs to make sure we're as prepared as possible for winter. So we've got this small window to try and get as much of the elective activity going as we can, whilst at the same time making sure we're ready for the surges that are going to be happening in winter. And also we are still preparing if there is another spike, either locally or nationally, and how do we next time switch off less services than we have had to switch off this time in order to get that round. So we are doing these, it's all on a number of different levels, but what we are really trying to do here is that we do need to switch on the services that give us a maximum health benefit. So when we've still got staff working in different areas, we still have COVID patients in, we still have very stringent infection prevention and control measures that we have to adhere to. So simple things can be quite tricky. So we have to focus on the maximising health benefit, because I think we recognise we can't do everything straight away that we were doing before. We have to do that always looking at the clinical evidence base. That's what we're doing, and that's why our clinical group is so important to what we are doing. We have made a big commitment around inequalities, and that isn't necessarily making sure that we have everything provided everywhere. What that means is patients, regardless of where they live in Cambridgeshire and Peterborough, can get access to services. Now that might mean a bit more travel than previously, but these are the things that we have to do to make sure they get equal access to services, because we can't physically provide things everywhere. And then lastly, making sure that we are redesigning pathways fit for the future and locking in some of the benefits that have occurred. So that's our approach. But I do just want to say one thing: we're trying to maximise this window, and I know this is the same everywhere, but our staff are pretty tired. People have been going at this a long time now, and so we are balancing off making sure people get rest and leave to be ready for the impending winter, whilst trying to switch on services and prepare for a possible second surge. So that's quite the balance, and so we are not able to switch everything on quite as quickly as we would like. But the latest Simon Stevens letter made it absolutely clear that we have to do as much as we can to get back up to last year's level of activity in our hospitals. From our point of view, and from my point of view, we are trying to really balance off to make sure that the national focus on waiting lists in hospitals is also balanced off by the need for community services, mental health, and how we're accessing primary care. So our local solution is very much keeping that all in mind. But I think nationally, the concern is very much that we're building waiting lists that are now are going to be very, very tricky to recover. And we have to think very carefully how we're setting expectations with the public as to what the health service will be able to do over the coming days, weeks and months.
Jan, thank you very much indeed. Questions, members, to Jan, please. Lucy.
Sorry, I didn't necessarily mean to jump in before Linda, but one of the things, just to pick up on that last point about capacity, one of the things that has happened during the outbreak is that quite a lot of private capacity has been brought in to support the NHS.
Yep.
I just wondered how long you feel you've got that capacity for. I think it's still there at the moment, because presumably if that is still available, that would be really helpful in helping with recovery. And I just wondered whether you've got information about how long it will be available to you.
Yeah, so so the guidance that we've been given so far is that it's there and we can continue using it. There is a review of that. I think it's the end of September. And I think rightly so. It's a kind of, if we're not using it, then why would we spend public money on it centrally? So that will be a bit of a use it or lose it. We are using it. We are using it a lot, both across all of our independent sector providers, and not just the private hospitals as well. There are other independent sector providers, particularly around diagnostics, because diagnostics is a key bottleneck in all of this. So we are using it. We welcome it, and we're going to do everything we can to try and keep it.
Thank you.
Thank you. Lorna, please.
Thank you. Thank you very much indeed, Jan, for that introduction, which was incredibly helpful. Two questions. The first one is the phased approach to recovery, and the kind of unwritten assumption in that recovery is a fairly linear process of improvement out. Now, from what you were saying, and I think from what we all fear, recovery may be anything but linear, and clearly you're coping with a lot of unknowns there. I'm just wondering how you plan for those unknowns and possible turbulence rather than the straightforward improvement outlined in that NHS England grid. The other question was really about, I mean, you've named a number of challenges, not least, I think, the pressure on staff and on people in all of this. What do you think are the most significant challenges that you've faced in recovery planning to date? And which do you think are the most significant ones that are likely to cause you issues in the next 6 months?
So we are, it does feel at the moment like there are some conflicting priorities. So I think, Lorna, your question is a really smart one, because what we're trying to do now is manage this on risk, and manage it all on clinical risk and clinical advice. And that actually cuts through a lot of what we're looking at, because if we concentrate on those objectives that I said about health benefit, actually that helps us quite a lot. So I think in terms of balancing, what we're just trying to do is work out really the rules of the road around infection prevention and control. How do we do as much as we can to keep all of that infection prevention control in place, whilst being pragmatic and balancing off that risk between not treating people because we can't fit them in, and the risk of treating them and then becoming infected with COVID. So that is the real balance, I think, that all the clinicians are really working through. And earlier on, I just chaired the infection prevention control board, where actually we were talking about that exact balance, and are we making sure that we get that right. So I think that's really the key to it, but we're really being really supported with the and listening to the clinicians on that. And I don't mean to kind of sound a bit glib, but I think they've, you know, the clinicians all through this have really guided us. Certainly people like Fiona Head, our medical director in the CCG, has been absolutely critical to really holding us to account for those health benefit decisions. So I think in terms of balancing it going forward, we're probably not going to get it right all of the time. And I think we do need a conversation with the public as to how complicated that picture is, because it isn't going to be as quick and responsive as it was previously. So in terms of risk, I think there is a couple of things. I think the first risk, these are in no particular, I'll just give you three, the three, I won't tell you which one's first, second or third, but I think getting additional capacity for diagnostics is really, really important for us at the moment, because all roads go through diagnostics, and things like endoscopies are the most are very high risk as well from an infection prevention and control. So I think for us, spending a lot of time on diagnostics, seeing how we can get more additional capacity in, and actually that in the communities as well, so that GPs can get direct access to those services is one of the big priorities that we really have to deal with. I think the second thing is just getting people's confidence up on that with that infection prevention control, and doing everything we can, but as I said before, keeping that balance, because we do need to get some volumes through, and we do need to keep those volumes coming up. So getting that balance right, I think, is our next challenge. I think the third challenge will actually be something that Liz can talk about, is that the more we can get the test and trace right, the more that we can get the scanning right, the swabbing, all of that, actually the safer those environments become straight away. So we're also talking about how we use the technology in sites that gives you very rapid COVID results when people are coming into hospitals, so that they only have to wait 90 minutes rather than hours. So getting the technology in place to make sure that the impact of the COVID is minimized and we can make assessments a lot quicker, I think is on that list as well. But to be honest, at the moment, you know, we are our clinicians are really worried about patients waiting on waiting lists. So the clinicians are going through all of our waiting lists, prioritizing them to make sure that we're trying to treat the right order, which is a move away from it's my turn next. So you know, I think but I think from a clinical safety point of view, that's an important thing we've got to do right now when you can't treat everybody. Does that answer your question, Lorna?
I think so, yes. I mean, I think that's given us some really helpful insights, so thank you enormously for that. Yeah, Tara.
Yeah, thank you, Jen. That was really, really insightful. Susan, please.
Thank you, and thank you, Jan, for your you know, your openness and about the challenges, which is really helpful for us to understand what's going on. I wanted to ask also about the funding, the sort of the more I don't know if relaxed feeling is a term you could possibly use in this situation, but funding pressures will come back. So I wanted to ask if you could give us a sense of that. And also I wanted to ask about workforce issues in terms of workforce retention, especially of the short-term positions that we rely on, and that kind of continuity.
So can I start with the workforce bit, because I think it's huge for us at the moment. If people, I think I've said this a number of times in health, if people offered me money or people, I would take people every time, because we can't do it without the people to do it. And we've had lots of people step forward. We've had lots of we've created, I think, a flexibility in our workforce that we haven't seen before. So, you know, obviously COVID has been an absolutely a huge and very, very difficult thing for, I think, everybody to deal with. But there have been some positives, and actually the workforce flexibility, our ability to retrain, reprioritize staff at short notice has been really, really good, and we don't want to lose that. So if we think about how we were managing to retrain people to work in critical care environments in very short spaces of time to make sure that they felt prepared, and then building the management structures to make them feel supported, I think that teaches all of us quite a lot of lessons actually about how we create a more flexible workforce going forward. And those principles are certainly being thought through in terms of what we're doing. And I think also in things like our discharge to assess pathways, where the community staff and the local authority staff have been working much more closely together in a much more fluid way, has again given us some lessons. And what's very interesting about that is when we ask staff about it, that's what they like. They like the variety. They like to be given different opportunities, more training, and be moved around. So that I think is a really important thing. But to be quite frank, Susan, we're always going to have to keep looking for different ways to get people, using apprenticeships, using different educational forms. We've just had a conversation earlier on this morning about areas with high redundancy. What skill sets are those organisations letting people go got? How can we use some of those to make sure that we can reintroduce them and use them in areas like health? So there's a big push there on workforce. In terms of the money, so I think there has been, I think there's been a helpful learning around this, which is how helpful we've spent so much time, I think, across health, and I would say care as well, talking about money in the last few years. I think what COVID did was give us one singular priority, and therefore actually money wasn't a big conversation. And I think we all found that, if I'm quite frank, thoroughly liberating. Because actually what it allowed us to do was have the real conversations that we wanted to have about people, about what was the right thing to do, and not necessarily talk about starting with the constraints that we've got. Now, I'm actually not convinced that that means that we spent huge amounts of more money. I mean, we did have additional COVID costs, but actually the partnership working that's come out in the last few months has been astonishing, and Cambridgeshire and Peterborough, I think, has worked together in ways it has never worked together before, and that is purely because we were all focused on making sure we could do the right thing. So I think the money I think nationally they've realised that and are very keen for us not to lose that sentiment. So in health, we are still very much being heavily encouraged to do that system view on money. We have different arrangements in place for the acute hospitals at the moment, and the NHS providers, so they get paid a direct payment straight to them, and then we top that up based on cost and what they're spending. And then obviously we still have to do things like maintain the mental health investment standards. We know those temporary arrangements are going to be in place for another month or so, and then we're waiting to hear what the new financial regime is. But I think we've all learned lessons around actually, if all of the focus all of the time is on the money, which we all think is hugely important, actually you don't get to the best answer for pathways. And I think that's what the new financial regime that we're waiting to hear about nationally has got front and centre in its minds.
That sounds hopeful. I guess.
Thank you.
Whether it's more money though, who knows? But
yeah, who knows? Thank you, Dan.
Might be some more freedom.
We've got about 8 minutes left. I really don't want to go over this if we could possibly help it. Linda, please. Linda Jones.
Thanks very much. And it was fascinating, really, because the paper itself is sort of dry as dust. all the structures, you know, I mean, it's actually, no, I'm serious in a way, because there's an issue about transparency here. Because, you know, people will come onto the website, some of them, not that many, not hordes, and the residents will look at the paper and they won't be able to make anything of it. If they have the chance to come and listen to you, they will understand what's going on. And we shouldn't have that, you know, that situation where the paper is opaque and you are being very transparent. So I would rather have, next time, 3 paragraphs from you and not all the structures. I read through paragraph, I mean, we're insiders on the committee, and I read through paragraphs 4 and 5, which was about all the conflicting structures, the competing structures, or are they supportive structures? You know, the STP, the COVID stuff, you know, I think we're talking actually about a lot of the same people in a lot of these groups, but you wouldn't be able to understand it if you were an ordinary resident. So please, can we have sort of less? And I think in this case, less is more. The other comment I have is that I sort of read paragraph 8 with interest, which was talking about the new ways of working that are going to be incorporated. And then, of course, you didn't tell us any. The paper goes on to talk about other things, talk about Simon Stevens' letter and prioritisation. Doesn't come back. But you talked about flexibility. You talked about digitisation and a whole range of things there. You talked about workforce, which is mentioned right at the beginning and then actually doesn't come back again. So there are really interesting things in what you've said, but please, can we get the alignment right between the paper and the person?
Okay, Linda, I'm sure Jan takes that on board. Thank you. Jeff, please, last speaker, Jeff.
Yes, thank you. I may have missed the opportunity to declare, I'm not sure whether this is a declarable interest, but my wife formerly was a partner in one of the larger GP practices in South Cambridgeshire, and is now a GP at Adam Brooks' A&D department. And of course, as such, she gets accosted by former patients. She's also a patient at another practice in South Cambridgeshire on her own account, and of course works with her colleagues at A&D. And so the point I wanted to raise is the disparity that seems to exist in GP practices in the region in terms of how quickly they are into a normal service, and in particular, concerned that some practices are way behind others in terms of allowing a sort of physical consultation and sort of, I was sort of describing an encounter with a former patient, I think yesterday, where she'd actually gone through telephone triage 6 times about a back pain. And the typical thing is, well, that could be a urine infection. So, here's a test. But basically the focus is on keeping the patients out of the practice physically, which, and we talked about this window. Is there anything we could do to kind of make this more uniform response?
So I think primary care have responded really well when the pandemic kicked off. We invested huge amounts in IT in primary care so that they were kitted up, ready to be able to do more virtually. And I think if you remember, our long-term plan aspirations were very much around using more digital and virtual. But we think there's a line. I mean, we've gone right to one end of the scale, and we need to bring it back into a sensible middle place, I think, which is not everything should go back to being face-to-face. We need to keep that virtual, but actually not everything can be virtual, and actually one face-to-face appointment might save time. So we're just working now with the local medical committee, the LMC, and the GP federations to try and make sure that every practice understands how they get to that right position in terms of treating patients. And we're also asking them to share best practice. I think one of the challenges we've got with primary care, and I think we've said this a lot, we do have 80+ individual organisations of varying size, infrastructure, etc., to be able to do this, and various standards of facilities. So we are having to do this very much on an individual practice basis to make sure that we get that right, and that is much more difficult than working with, say, one hospital where you can deal with one person. And that's why using groups like the federations and the local medical committee is so important. But we certainly recognise this disparity that we've got to keep working through with primary care to make sure. But I do want to say they really did step up that other virtual stuff really quickly to make sure that people still could get access in a way that I think was quite extraordinary. Now we need to support them back to that level of moderation.
Thank you.
Thank you, Jeff. Yeah, as ever, I think that was a interest. So thank you for mentioning it. And James would have made a note of that. So thank you. So, excuse me. We've been invited to note the work undertaken to date of the recovery planning, which we have done. Jan, thank you again. And that's exactly half an hour, so that's really good. Thank you for your time. Do you have any more comments before you go?
Well, I just noticed the last discussion, and I'm going to unashamedly now promote something called BMI Can Do It. So we've been working with Val and everyone because we've recognised that benefit in our recovery around that balance between not actually just weight, but sleeping well and moving more. So there's a movement being launched with colleagues in public health to really push that. You might have known the website, we're kind of pushing it everywhere. So I would encourage people to look at it, but that element of sleep and moving more is really important on that kind of triangle. So we're working with colleagues in public health, but if we're going to get people as fit as possible to be prepared for any second wave of COVID, then actually this well-being is a real part of our recovery plan. So do go and have a look and come back. I'm more than happy to come and give you more details about that if we can.
Thank you, Jan. That's really good. And thank you very much for your time once more. And please pass on our thanks to all your staff for their hard work.
I will do. I'm going to log off. Thank you very much. Bye-bye.
Yes, please. Thank you. Bye-bye. Jeff, could you take your hand down, please? Your blue hand, if possible. Thank you. Thank you. Can I please now go on to agenda item number 5? This was circulated on an email from Rob Sanderson at Democratic Services on the 4th of August. And given the rapidly changing situation and the need to provide the committee and the public with the most up-to-date information, I have accepted this as a late report, and I have to tell you why. So the first was the reason for lateness is to allow the report to contain the most up-to-date information possible. And second, the reason for the urgency is to enable this committee to be briefed on the current situation in relation to Council's response to COVID-19 and for those services for which it is responsible. So now can I ask our Director of Public Health, please, Dr. Liz Roman, to introduce the report. Liz, thank you.
Thank you, Councillor Hudson. And this is the third report like this that I have presented to you. And it does build on the information that the committee already receives in your public health highlight reports. So I think it's particularly important this month because many committees are not meeting in August. So this is very much the public report on the COVID response that is coming into the public domain and gives you the chance to really take an overview of what's happening. So it is particularly focused on the public health context. And just moving to section 2, as I've said before, over the course of the pandemic since March, many cases of COVID-19 have not been tested for or diagnosed. So we provide you with information on confirmed cases who've been tested, but that's inevitably only a partial picture of the overall pandemic and its course. But it is useful to look at both the historical rate and the current rates. And when we look at Cambridgeshire and Peterborough, our neighbouring area, if you look at all the cases of COVID-19 who have been diagnosed since the start, the rates in Huntingdonshire and Peterborough are higher than the national rate, statistically significantly higher. But what's interesting about that is that whereas in Peterborough, that rate at this point is still high. So in Peterborough, the rate of COVID-19 cases per 100,000 is still around 20 against a national average of 7. If you look at Huntingdonshire in the table on the top of page 3, Huntingdonshire has come down and is now running very much at an average rate in comparison with the rest of England. And as with all the Cambridgeshire districts, you do get little fluctuations. It moves up and down, but from a base of low numbers. So that could be quite limited transmissions, say a family group or something like that will have an influence on those numbers. So the overall picture is that Peterborough is still has relatively high rates. Cambridgeshire overall has a rate which is similar to, slightly below the national average. That I think is an important picture. We look at the weekly rolling average, so the last 7 days. I actually look at that every day along with members of my team for Cambridgeshire and for each of its districts. And you can see that that's increased in the graph on page 3. You can see how that has changed over the course of the pandemic, and that really since mid-June, it has been relatively stable. There's a very slight increase in recent weeks, but again, that may either remain as a slight increase or it may come down again. We haven't really got a very clear trend there. And rates are much lower than they were back in April, May. But it's there. What that also shows is that we still have a level of transmission of COVID-19 in the community. So we are not completely out of the woods, and it's essential that people continue to follow the government guidance on what you can do and what you can't, that they continue with social distancing, continue with good hand hygiene, wear face coverings are required, and self-isolate with their households immediately if they get the symptoms of COVID-19. Also, we've talked about the importance of test and trace. Jan mentioned that, and that people do, if they're contacted by the National Test and Trace Service and asked to self-isolate because they've been in close contact with someone with COVID-19, it's essential that people do that. So it's basic stuff. But I think our main worry in public health at the moment is that people relax because of the low rates and don't follow the things that the government is still asking them to do, which are less than was required during lockdown, but there still is that advice and those requirements. So I would just put in a plea really to yourselves as advocates for health, that you encourage that ongoing observing of the government guidance on social distancing and those other key points. But that is where we are at the moment. On the deaths, sadly, we've had, I think it's now 400 COVID-19 related deaths in Cambridgeshire. There were 399 in the period from March to June. There has been a small amount of further deaths since then. But when we look at those death rates from March to June, and I have actually circulated you a correction to this paper because the COVID-19 related deaths table was duplicated twice. So you had the same table for COVID-19 related deaths and all cause deaths from March to June. We have found that all Cambridgeshire and all our districts were better than or similar to the national average during these 4 months for COVID-19 related deaths. And also for all cause deaths if there were COVID-19 deaths that were missed. That is quite encouraging in terms of the overall progress of the pandemic in our area, and in terms of the transmission rates to people who were more vulnerable in our communities. It does show that our communities have been less affected than in some other areas, including some other areas with similar demographics across both Cambridgeshire and Peterborough. And that is positive and reflects in many ways the behaviours of the public and the way that the public has followed some of that guidance. We also have a map now. This has been published nationally, but also locally, of the deaths by geographical medium super output area, which are areas of about 7,000 people. This does show generally higher numbers of deaths in Fenland and northeast Huntingdonshire, and also in some parts of Peterborough City. We have to be a little cautious because this is numbers of deaths, not rates. And where you have an older population, as you do in Fenland, people will be much more vulnerable to poor outcomes from COVID because of their age. But it does show us some of the impacts in a more localized way, which I think is helpful when people want to understand the local experience. And clearly every one of those deaths is a tragedy for the families concerned. So there is significant experience there. Where we see very high rates in a small area or one medium super output area, that's often areas where there are a lot of nursing or residential homes. So you will see that. So it doesn't necessarily mean there's a high rate of community transmission or deaths in that area. It can be about nursing and residential homes. We haven't included this sort of detail before in my report, so I have gone into some detail describing it. I think other key points that I'd like to raise today, which haven't been raised in previous meetings, are the publication of the COVID-19 Contain Framework. So that was published on the 17th of July, and that's the national framework. And some new powers for upper tier local authorities were published as really setting out how national government and local government would work together with the Joint Biosecurity Centre and Public Health England to prevent and manage local COVID-19 outbreaks. So that was an important publication. The new powers that it brought to us as Cambridgeshire County Council are important. So district councils and city councils had powers to close down premises for public health reasons if they went to a magistrate and asked for this with the advice from a proper officer from Public Health England. So that power has now come to Cambridgeshire County Council and can simply be done through the council without having to go to a magistrate. So the powers that this Contain Framework and the associated regulations give us are to close a premises where there's an immediate risk to public health due to COVID-19, to say that an event cannot happen, a public event due to, again, a high public health risk from COVID-19, or to say that public outdoor spaces can be closed due to that risk. And this is COVID-19 specific, whereas the powers held by district councils are general public health powers, which could be used for COVID-19. So that is an important change. What those powers don't give us, they don't give the county council the power to close down a street, and they don't give the county council the power to close down a business sector. like say gyms or swimming pools. Those powers still sit with the Secretary of State, with national government. So I would say that if you're talking about a local lockdown, quite a lot of those powers still sit with national government in consultation with ourselves. But if you're talking about closing down a premises where there is an outbreak or preventing an event that's high risk from happening, we now have those powers, which previously sat through quite a complicated process with district councils and magistrates. So that's a change for us. The other thing that, or one other thing that the Contain framework did was it outlined the level of concern that there might be about a local authority area. And this is really driven by the Joint Biosecurity Centre, the national body which reviews all the data on COVID-19. And that puts most local authorities are not in a category. But where rates are higher or there are issues of concern, there's 3 categories for a local authority. The first is an area of concern, a watch list of areas with the highest prevalence, where the local area is leading targeted actions to reduce that prevalence. And Peterborough, because of the higher rates that I outlined earlier, is an area of concern. So that's a close neighbour for us. And indeed, we have a joint public health team working across. There's then areas of enhanced support, where there has to be a more detailed plan agreed with the national team and with quite significant additional resources being provided locally in terms of expertise. And finally, there's areas of intervention when the national rules around COVID-19 for England don't apply. So there may be a local lockdown. It may be that the relaxation of shielding or pausing of shielding doesn't apply, or there may be specific measures about sectors of business which can't open, for example, gyms or swimming pools. So it's not always the same intervention, but an area of intervention has a difference to its rules. So that's important as well. There's more information about that available on the web, and we will have to redraft our local outbreak control plan and associated roles and responsibilities to take into account these new powers. That process is happening at the moment and will be brought to you in our next report. So that's a significant national change. In terms of implementing the local outbreak control plan, in a sense, less change since my previous report. I think many of the things in here we told you that we were planning to do and starting to implement, but paragraphs 3.6 through to 3.12 are really mainly things that we told you we were either doing or planning to do, and this just summarizes that for you. Both the work that goes on every day through the surveillance cell, the outbreak management team, and our various cells for outbreaks in workplaces, in schools, care homes, and vulnerable populations. And then the governance arrangements around that, and the member-led local outbreak engagement board, which Councillor Hudson sits on. 3.10, paragraph 3.10 lets you know a little bit more about the allocation of the Test and Trace grant. We have an active finance subgroup of the Health Protection Board, which has approved funding for a number of different ways to increase capacity within the system. And some of that has gone on increased public health capacity, but also environmental health communications, testing capacity, training capacity, and a hardship fund for vulnerable residents who need support to self-isolate. So one of, I think, the things we need to look at for the public health grant going forward is where we've increased capacity around COVID-19, whether any of that may be needed going forwards, given that this will be, I think, a long-term issue for us, and also may be useful for other infectious disease challenges such as TB. So that is the overview of the implementation of our plans and what we're doing on local outbreaks. The Local Resilience Forum, co-chaired by Gillian Beasley and Jan Thomas, also plays an important role in bringing in the wider system for mutual aid. And the Local Resilience Forum has run an tabletop exercise to test our plans and the rapid response in districts. That took place on Monday, the 20th of June. It was well attended. It was the first virtual exercise that our LRF had run. And obviously the outcomes will be reviewed and incorporated into our delivery. I've also included some information about asymptomatic screening at factories in Huntingdonshire and the ongoing work that's continuing alongside our specific COVID-19 response arrangements and our recovery work, which, as Jan outlined, is very important. We're working on COVID-19, but we need to work around TB, healthy weight, health inequalities, and a number of other issues at the same time, which can be challenging. So that is the overall summary, and very happy to take questions on the paper.
Thank you, Liz. That's a very good in-depth introduction to the paper. Should we start with Anne, please?
Thank you, Chairman. Liz, I'm very glad you mentioned the COVID-19 related deaths and all-cause deaths. That was going to be my first question, that about them both appearing to be the same. You said you sent out another email. Can I ask that you resend it to me? I'm not sure whether I received it and thought it was a duplicate and deleted it, or just didn't receive it.
I actually sent, I did send it quite recently. I sent it actually during the committee, because I was sent the amended paper. So, and it's possible you're not.
Have a look and I haven't received it.
Okay, it went to the Health Committee circulation. We must check that you are on that list, having joined relatively recently, Councillor Hay. I'm concerned now that you may not be getting other Health Committee circulations. If
Liz, I've just sent that, Anne. I've just sent that email.
Yeah, but my next point was, at the end of the report, under 5.1, it mentions about the government's recovery plans for the UK and the requirement for people to get back to school and work, for communities and to services rebuild, and for businesses to reopen, etc. What are we doing as an authority to get our officers, and indeed for that matter our members, back to normal working practices within the office, or is there no plans yet for that to happen?
That has been reviewed very carefully. There is a health and safety group that is overseen by our Director of Customer Services and Digital Services that brings in health and safety, public health, premises, other parts of the organisation. And what that is doing is looking at COVID-19 safe working, following the national guidance for workplaces and offices. So we want to, well, we're already doing quite a lot of normal working, but on a virtual basis. So just as with this committee, we're doing a lot of work through virtual meetings rather than everyone having to be in the room together, and a great deal of work is being done. In terms of return to offices, that is being managed very carefully. So all offices and the work of all teams is being risk assessed, so that we can bring people back in a proportionate way, because clearly with social distancing, we can't bring everyone back to the same extent that we had beforehand. So that is the subject of very detailed plans about the people who really need to be back, the people who can work from home, and how we balance that out and do it in the appropriate way. And a huge amount of work has actually gone into that, and that is progressing carefully. At the same time, quite a lot, we've surveyed our staff, and actually quite a lot of our staff appreciate the opportunity to work from home. They can do it effectively. It reduces travelling time. The fact that I certainly find I'm spending much less time travelling, and therefore I'm able to work very solidly throughout the day. And I think staff appreciate that. But what we are doing is that we are looking at risk assessing people's home environments, just getting people to do their own basic risk assessment at home, so that we can be sure that people are working in safe environments that won't harm their backs or other things, because they're not working with appropriate chairs and equipment. So we're not looking to go absolutely back to normal. We're looking to go to a new normal, which is COVID-19 safe, and is COVID-19 safe both for workers in the office, workers who are going out, and workers who are working at home. So a great deal going on there, Councillor Hay.
It's just I'm very concerned that the government is saying to businesses, wherever possible, please get your people back into the office. And as a local authority, I think it's incumbent upon the local authority. Obviously, we have to make sure it's safe for officers and for members to go back into Shire Hall. but we need to be setting an example. And for instance, the council chamber itself would lend itself to quite a number of committees while still being able to keep your distance.
Certainly that has been looked at, and again, these things are subject to very careful risk assessments, Councillor Hayes. So I'd be happy to share some of that work with you. It's not all led by public health, but every environment is risk assessed and thought through very carefully. So happy to share some more of that with you outside the committee, if that's helpful.
That would be very helpful. Thank you for that.
Okay. Thank you.
Thank you, Anne. Lorna, please.
Thank you. There are two things I was going to say, and then I just want to pitch in on the discussion that's just happened. The first question that I wanted to ask was, how frequently are we now receiving postcode level data, and how far have we got with regular arrangements for sharing that data with the districts? The second thing I wanted to say was that I have enormous admiration for everybody at local level who is trying to make all of this work. And I would just observe, and I don't expect Dr. Robin to comment on how difficult that is when the messages from central government are so confused. Nobody, literally nobody, knows what the rules are anymore. The health secretary doesn't know what the rules are. The rules that are being portrayed are contradictory, incomprehensible, and just thoroughly confused. And it's really, really hard for everybody, I think, to understand what they're supposed to be doing. And it's hard, I think, for us as members to be able to convey the messages when the messages either are incomprehensible or just don't make any kind of logical sense. And I mean, I'm still very much in the mode of simply saying, stay at home as much as you can, don't meet people indoors, wash your hands, wear a mask when you go out, and just do what you used to do before everybody was trying to loosen up. And I struggle with the complexity and the confusion that now abounds about what people are allowed to do, what they're not, and what's wise and what's sensible and what's safe.
Lorna, do you have a question for the Director of Public Health?
Well, the third thing I wanted to do was to pick up on what Councillor Hay said, because I do worry, and I welcome Dr. Robin's observations on this. There seems to be no need to pressure people, to pressure our own staff and our own councillors into making unnecessary journeys across Cambridgeshire and polluting the atmosphere as we used to do, and putting ourselves and other people at risk by gathering together and moving about unnecessarily, just to prove some kind of a point to people going to work in other environments. It doesn't seem to me a wise course of action on a health level, and it doesn't seem to me a wise course of action on any other level that I can think of, environmental or otherwise. And I would really want to encourage Dr. Robin in her advice to take these things one step at a time and not pitch in order to wave some kind of flag about needing to get back into offices. Thank you.
Right, okay, Lorna, thank you. There may be a question in there, I'm not quite sure, but I think Councillor Hay was more concerned about you do, but we're not doing. She thought we should lead by example. As a civil servant myself at the Ministry of Defence in my other life, there is some form of return to work, albeit slowly, too slowly, because we could isolate ourselves at work quite easily. And if we encourage people to go to work, perhaps we should say, well, we go to work too. But that's a decision that's a more senior level will take. Let's go to the Councillor Jones, please. Linda.
Sorry, Chair, I did have a question. I asked a question.
Oh, well, I've asked you if you had a question and you just went on. So give your question now, please. Give your question now and the Dr. Obi will answer it and we'll move on.
It is the question I asked at the beginning of my speech. Thank you.
Well, who could remember? Can you remember, Dr. Owen?
Yes, that's fine. I do note the question.
Goodness for that.
Asked. So there was a question about whether we're now receiving postcode information, and the answer is that yes, we are. And there is some postcode information coming through one route to information analysts, and there is also postcode information coming through daily, which is very up to date, and that's very helpful. There's been increased information sharing with directors of public health and some officers there. So we do have much better information now than we did in terms of really being able to track what's going on and deal with outbreaks. That's greatly improved. In terms of the data sharing agreements with the districts, we are very, very nearly there. We have our agreement with the districts finalised. We just need to get 2 points resolved with Public Health England that on our information sharing agreement with them, that they are happy with our data sharing with the districts. So we've been working on that for some time. We do share a lot of information with the districts. This is about actually giving them the data. The whole data set, rather than just sharing with them a lot of the useful information that they need day to day. So that is very much progressing, but we just need that final bit of feedback, which we're hoping to get. I would hope to get it this week or next week to finalise the actual sharing of the whole data set.
Thank you very much, Dr. Robin.
Thank you, Liz. Councillor Jones. Linda, please. Thank you.
Thank you. And just to comment on the previous discussion, I did have an exchange with Liz about postcode information. I think Liz is now saying that daily information is coming to Peterborough. I'm not sure daily information is coming across Cambridgeshire. So perhaps at some point she'd just confirm that. The other issue that I raised was about what the postcode information does if it's not linking to a work setting. Because if you now have the power to close down premises, you need to be absolutely clear what that postcode is referring to. And we know that in some cases, the information about the employee, which is one of the categories that can be used, is not always completed. So perhaps at the end, you could come back and just close off those loops, please. I know that I'm very much aware that directors of public health all over the country have been beavering away, trying to get a level of local information that means that they can tackle outbreaks locally with the greatest efficiency, and that's absolutely spot on. There are just a couple of other things, if I could flag. One is about the table talk. Well, one is about Peter's work. And not necessarily now, Peter, but if you could tell us something about what the member-led board does. I noticed the next meeting is on the 7th of August, and I noticed it's in public. So if we could have a link to be able to view that, that would be great for those of us who are not going on holiday at some point. It will be interesting to hear what goes on there, because that's obviously, in terms of democratic accountability, quite an important board to be involved in. And the other question I wanted to raise was about what emerged from the tabletop multi-agency emergency planning exercise, because that again sounds very worthwhile. Clearly, if we do get a spike in COVID, if there is a combination of COVID and winter flu, those multi-agency manoeuvres could be very important in terms of being very effective in meeting that. So I'd welcome a comment on that if I may. Thank you.
Yeah, Linda, really that's good. Thank you. I'll start. In fact, we have a meeting tomorrow and a workshop tomorrow. And I'll be very glad to contact you and any other member of the committee and give a report of what we're doing and how we're doing it. And the meetings are in public. And James, could you make a note, please, to make sure all members have the information they need to be able to view the meetings, please.
Thank you very much.
Okay, good. Yeah, no, thank you. You're very welcome. Liz, sorry.
Okay, so just running through the questions. The postcode data is coming to us for both Cambridgeshire and Peterborough, Councillor Jones. So that comes through to Directors of Public Health regularly.
Sorry, Liz, is that daily? Because I know that Peterborough is in a pilot for daily information, but is the whole of Cambridgeshire in that?
It's a different pilot, I'll explain. So I get daily information for Peterborough and for Cambridgeshire which includes the postcode of all cases. In Peterborough, and this is, I just need to be a little bit careful, but we are looking at participating in a pilot which would give us further information, even more detailed information. So I'll feedback on that going forward. But I do get daily postcode information for both Peterborough and Cambridgeshire. I can assure you of that. And have enabled a small, because obviously it's very sensitive, the information that we get through alongside some of that enabled a small number of others in the authority to also receive that for operational purposes. To make sure that we're managing outbreaks well. I absolutely take your point about workplaces. I think people quite often fill in the web-based tool sometimes and don't always fill in their workplace, or it doesn't always get recorded fully. And so you will get a postcode, which is someone's postcode of residence, but you may not always have that information about what's happening in a workplace just through the way that is recorded on the system. And there may be a number of reasons for that, including people, whether they always sort of want to give their workplace is a question. So we would encourage local workplaces, if they become aware that they've got a case, to contact us directly. Because we may find out about a workplace outbreak through the classical sort of test and trace national to local route. But we may also find out about it because we're contacted about it locally. And in fact, I have written to businesses in Peterborough, and I hope a similar letter will be going out to businesses in Cambridgeshire in a not too distant future as Director of Public Health, with a little flowchart of what businesses can do and how they can contact the local health protection team and the local authority if they are aware that they have a case or an outbreak. So we want to promote that local information flowing in as well. In terms, and actually the multi-agency exercise, the draft outcomes have been prepared, not the absolute final ones yet, but one thing that's coming out of that is also the issue of working across boundaries, because outbreaks are no respecters of local authority boundaries. So we can encourage our local workplaces to report to us, but if people who live in Cambridgeshire actually work, say in Bedfordshire or Suffolk or Norfolk or Essex or Hertfordshire, whatever, or Peterborough, then if it's outside our area, then it can be more difficult to actually know about that outbreak. If it's east of England, we share a health protection team, so the relationships are good, so we're likely to hear about it through the east of England links. Probably the biggest challenge, which is more for Peterborough than for Cambridgeshire, is when we go into, say, Northamptonshire or Lincolnshire, and that's actually outside our Public Health England health protection team region, because it sits outside east of England. So we are working quite actively with regional colleagues and feeding back on this, and also contacting neighbouring directors of public health just to make sure that those cross-boundary issues are fully thought through. And cross-boundary issues was something that did come out of the exercise as one of the points that we need to be very clear on that.
Thank you.
Is someone on mute?
Yes, me. It's all right. It's okay. Thank you, Liz. Linda, thank you for your questions. Really good. Thank you. Lucy, please.
Thank you. I'll be quite brief because there are lots of questions. My questions are on the test and trace activity, which if you covered it and covered any of these, I didn't hear it, and so I apologise. But so the questions that I've got are around the percentage that we're managing to contact both for Pillar 1 and for Pillar 2 in the test and trace system. I think I'm particularly interested in the information you're getting on Pillar 2 testing. testing system. And I'd really like to know how much information you're getting from them on what their percentage success rate in contact tracing is for Cambridgeshire, and also what the delay is between them trying to contact somebody and then them handing it to you, because I think when they don't succeed, you get given that case. So it would be really helpful to know what the delay is before you get the case, because I think if we are trying to control outbreaks, that the speed of that response is really important. Thank you.
Thank you. Liz?
Yes, thank you. I'm trying to look at a number of things at once. So on the test and trace, we get information through. It's not differentiated between pillar 1 and pillar 2. We just now get information through, because that's different sorts of lab tests, but otherwise the process through test and trace is the same. The lab test results go into the national test, into the national contact tracing system. I haven't got the exact figures to quote for you. I was just looking for them then, but in Cambridgeshire, the figures, when you look at the figures of contacts traced when there's an outbreak in a setting like a school or a care home or a workplace, and contacts have to be traced at what's called tier 1. Those figures of contacts traced are pretty good. It's a very high percentage. When you look at the contacts traced by the national telephone and text system, then that's a bit lower. And I think for Cambridgeshire, we're looking at, off the top of my head, probably somewhere, it's in the order of 60% or a bit over that, but overall it's much higher. I believe it's over 80%. I'll get back to you with the definite figures, because obviously they change each week. So but it's that sort of order, and Cambridge isn't doing badly. One of the issues we think is that when you look at the national systems, there's a sort of requirement to talk to every contact before you can record them. And so sometimes if you get a household and maybe that household doesn't, not everyone in that household wants to have a separate conversation, then sometimes the head of the household or a couple of people in the household might take the information on what everyone needs to do, and make sure it happens, but not everyone's being talked to, so that counts as a failure. So we feel we need to have a lot of discussions about exactly what some of that means in different circumstances, and we are increasingly in communication with the national systems about that. But we are getting quite good information. I do get daily information through now on contact tracing as well as Director of Public Health, so that is a lot better than it was. But yes, there is a movement. It's not something we're doing in Cambridgeshire at the moment, where we have talked about it, a pilot that we were going to participate in, actually in Peterborough, but that has been altered, and some of those pilots are not going ahead, but other things are happening. And at that point, we did have a proposal that we would have the cases who hadn't been traced handed down to the local system after what seemed like rather a long delay. What I can say is that in the new model, which is being developed, and which some areas like Blackburn with Darwin, Leicester, a couple of other areas are currently implementing, is that there's a more rapid hand down after 48 hours rather than after a longer period, Lucy. So I hope that helps address your concerns.
Slightly, although I have to say, I mean, if that's only in pilot areas, what is happening about if the national system doesn't succeed in contacting somebody, what is happening in Cambridgeshire at the moment?
At the moment, those cases would not be contacted. They would be counted as failed contacts. So that is.
So they're not traced at all.
Yes, they would be lots of efforts would be made to contact them, but they wouldn't be handed down locally at the moment. And obviously when it is handed down locally, you need a system set up to receive that, which is what we were aiming at with a pilot that was planned in Peterborough. We're now looking at going down other routes for that, but there have been, but it is focused at the moment, I think quite rightly, given that it is a new way of working on areas of concern. So local authorities of concern are getting the focus around this new way of working and the handing down. where there are the highest numbers. But certainly I would expect to see that being rolled out in future after the learnings. So I think I quite agree with you, Councillor Netzinger, it is very important, and we need to get those processes right.
Okay, that sounds as if there's definitely still quite a lot of work to be done in making that system functional.
I think yes, it will start in a smaller number of areas, make sure that it's functional, and then I would expect that it would be rolled out. But I'll get back to you with more information as soon as I have it.
Thank you very much.
Thanks. Can I just pop in there, because those questions from Lucy were really good, and for the first time ever, I went out with my wife yesterday. We had lunch, albeit briefly between meetings, and we were given a bit of paper for our test and trace details, which was fantastic. In the evening, we went out a table for 4 at a local restaurant on the outskirts of Cambridge with 2 friends of ours. And when I asked about the test and trace procedure, they said, "Oh, we just take the information from your booking." So they have my name and my email address, and they know it's a table for 4. Okay. So then we left there and we said, it'd be nice to go to a pub for the first time for 4 months. So we went into a pub, we walked into a pub, and there was stuff for your hands, and they had screens around the bar, great, and everything else. But there was no test and trace at all. Nothing, Liz. I don't know what we can or should do about that, or do we have any power to do something about that?
I think if we could talk about it outside the meeting,
Yeah, we will do.
What we do in that situation is contact our environmental health colleagues who can pay a visit.
Yeah, because I was really disappointed, and as Lucy quite rightly said, if there's work to do, these places like that should be doing it for us. Anyway, sorry, we must move on because time's getting on. District Council colleague Sarah, once again, you're very welcome.
Very much. A lot of the things I wanted to say have already been picked up, but just 2 questions. First one, is there any information? We had 74 confirmed cases the week 20th, 26th of July. Is there any information via the contact tracing about the method of spread for these people? Was it at home, work? Was it social interactions in restaurants? Was it family bubbles, meeting up, huge family gatherings at home? That would be interesting to me, and anything we can learn. And following up from what Councillor Dupre said, my gut feeling is that compliance with social distancing appears to be going out the window. The message seems to have gone. And for those of us that step aside on a footpath, you now get a funny look rather than a thank you for stepping aside. I ate out to help out last night, and it felt like eat out to spread the virus. There was no social distancing, not in Cambridgeshire. Where do we, as Cambridgeshire, fit with trying to reinvigorate these messages with our public? I know that central government, I think, holds the key to this. Remember, I'm new to this meeting, but how can we in Cambridgeshire just try and grasp this and try and get the messages out that please don't forget about this, please don't get fed up, please stick with it, to help us get through it?
I think those are really good questions, and talking about how did spread happen, we can't always understand it, but quite often we can. So we work very hard through the surveillance cell, which is led by one of the public health consultants in the council and includes analysts from a number of agencies. We work really hard to look at where we have workplace outbreaks or other outbreaks, to understand how many of our cases are accounted for by those outbreaks so that we know, and how many aren't. And we are getting quite a lot of information now. So for instance, if it's a household cluster, then we get the postcode information, so so we can kind of see where it's a household cluster and so on. So we do have much more information than we did about how quite a lot of the spread is happening. And Public Health England epidemiology unit also run reviews if an area is of a bit more concern, if there have been some more cases, not on the formal government list, but just a bit more concern. They will also run reviews of how cases might be linked. So we do have quite a good picture of that now. in terms of contacts, that is provided for us as well. So we do have some workplace spread. We have some spread that happens within households. So someone may catch the virus somewhere, but then spread it to their spouse and their children. So you may get quite a number of cases just from one family unit. And sometimes we may not be able to identify that, but we work hard at it. And compliance with the social distancing is extremely worrying, I think, because I think we had quite good compliance in Cambridgeshire for a long time, and that's one of the reasons why our death rates were quite good. And I think we got information out about it quite early as well, particularly to more vulnerable people, thanks partly to Emma Tiffin and her Radio Cambridgeshire programme, which was majoring on social distancing even before lockdown came in. What we have at the moment is our Caring for Cambridgeshire campaign, which our comms team have done, and our comms team are doing a lot of work on this. One of the questions, I don't think this is confidential, that we'll be asking at the local member-led board workshop tomorrow that Peter was talking about is how can we really work through our local members on county, district and parish councils and our community groups and our community leaders. How can we mobilise all sorts of community leaders much more to keep getting the prevention messages out? And I think that is really important, and we need to play that right as well in terms of the messages that will work for the different age groups and different vulnerability groups, because they may be different. We've done a bit, we can probably learn from Peterborough as well, because with the high rates in Peterborough, we've been doing a lot of messaging, and Peterborough United Football Club, POSH, have been, some of their players have started to give out messages, and apparently that's had a really good view rate from young people. And there's a few more things like that our comms team are working very hard on. But also we need local community leaders like yourselves to be totally engaged with that.
Yeah, and I agree with that. I think as district councillors, we have a much smaller flock, and we know who are the key people in our flock that will give out good messages, and it'll be a different role model in each community. So I think there's real potential there to try and use your district councillors to reinvigorate the messages. Let's keep going. Thank you, Liz.
Thank you. Thank you.
Thank you, Sarah. That's a really good question. Susan, please.
Thank you, Chair. Yeah, it's been very helpful to hear the many questions on messaging. I promised my local COVID group that I would raise the question here today, because there is real anxiety over confusion in what we're supposed to do, what we're allowed to do. And we're being asked as COVID response scheme leaders to provide advice, and we're confused, if I'm honest. You know, people do ask very detailed questions, and things are changing all the time. And so it's been good to hear that aired today. And my own reaction has always been to go to the public health advice rather than political advice. And I think, or rather not political messages, because, and as Jan Thomas said, the action in COVID response in the CCG has been led by clinicians, and everything is about infection control. So I think if we're going to be able to give a clear common sense message, that holds the key. So I hope that's, I hope I'm thinking in the right way, Liz, and I do keep going to the website, the council website, the public health posters. And somebody asked me the other day, do we have a poster on how to dispose of PPE in the black bin? A parish clerk asked for that. So there is real receptiveness to the key public health messages. Anecdotally, I'm also hearing about complete failure at some pubs and restaurants not engaging in the protocols you'd expect. And people know what those protocols are because another establishment will be doing things very, very well. And people are noticing, oh gosh, I'm I'm not going there anymore. I'm going where I feel safe. So I think all that feedback's really valuable, and I look forward to hearing from Peter about the workshop tomorrow. Sorry, that wasn't a question, but except that Liz will correct me if I'm going down the wrong path. I just wanted to mention a couple of other things if I could. One also relates to local support groups. The mention of the Hardship Fund for people, vulnerable people who must shield. Just as an observation, what we've learned locally is that the people who need Hardship Fund relief or food relief are not necessarily the people who are shielding. The people who are shielding often have very good links to food provision, either web-based or through friends and family, but people who need food. And our own local food support is continuing through the summer for families with children on preschool meals. But those are not the same people that we have been supporting in COVID response in terms of going out to do errands because people can't get out. So I think there's it would be useful to take that kind of learning back in case we have to go through these exercises again. And then finally, I wanted to ask, in terms of the local outbreak control group, Peter's group, we're calling it, I seem to remember that it would meet weekly if there was a local outbreak, and that the local member would, from the relevant area, would be invited to attend. But has that happened? Because it looks to me as though it's just met monthly, but maybe I didn't read that carefully. So I wonder how that's worked out, Peter. Thank you, that's all.
Okay, it hasn't happened yet because we haven't had to call a local member in for a spike, which I suppose is good, but there's no reason why that can't happen tomorrow or the next day. And we're on standby all the time if it's necessary. We'll meet at the drop of a hat, I think it's fair to say, and contact the local members of any division or ward, and then one member of those members, if there's more than one, will join us to talk about that particular incident. Liz, do you want to come back on this, please?
Yes, I think that's right. It's set up. It's not a decision-making committee, so it's been set up very flexibly. So rather, I don't remember saying that it would meet every week. It's the Health Protection Board, the officer board, that meets every week because there's a lot of work to do. So that is done very routinely. The local member outbreak board's been set up to be very flexible because it's not a decision-making committee. It can be called at a day's notice because it is an engagement board about communicating with the public rather than a decision-making board. So that is basically the setup. And as Councillor Hudson says, it hasn't been required to be called at that very urgent level due to high levels of community concern or whatever. It hasn't been required to date, but it may be in future. So that's the point I'd make on the local outbreak control board. In terms of the Hardship Fund, I did just want Susan to clarify something, which is that that is very much to support people who are required to self-isolate. There is quite a lot of evidence coming out nationally that people who, for example, are on 0 hours contracts or working for agencies who don't have a source of income, that may find it difficult to self-isolate even if they know that they have symptoms or they're told that they're a contact. So basically through the community hubs, a lot of support is being set up generally for vulnerable people who might need to self-isolate, and normally that wouldn't need to involve money. It might involve food, it might involve walking the pet, it might involve getting medicines, but we're also aware that there will maybe some people who actually get no income if they're self-isolating, and the hubs will work with them to see what could be done through rapid universal credit or things like that, but also have a hardship fund to ensure that they can self-isolate with support on financial issues if that's absolutely necessary. So it's been set up so no one should be stopped from self-isolating if they have an infection or are a close contact by lack of money, and they're not put in a position where they have to go into work because they have no other source of income. So that's really what that is about.
May I ask, through the chair, if it would be possible to disseminate information about that to members so we're aware in the community? I don't know how it works. So, I mean, how does someone in that situation take the initiative?
That would be when we did proactive work in an outbreak to identify people. It's not really for people who just get identified through test and trace. They're given the number of the local hub and asked to contact it. But what we're talking about, particularly with this group, might be a workplace outbreak and people on 0 hours contracts. And if we go into that workplace, it's really designed for that. If we go into that workplace, and there are people who might not, or we find out about a similar or perhaps a situation in a house of multiple occupation, something like that. It's those sorts of issues on outbreak management where we want to be sure that we can test people and actually encourage them to have a test, even if they don't have symptoms, and that they won't be put in an impossible position if that test result comes back positive. It's more those sorts of situations it's designed for.
Thank you for clarifying that.
Thank you, Susan, very much. Linda, please, Linda Harford.
Thank you, Chairman. Almost everything I've just checked that I was going to ask or say has been said, so I'm not going to repeat anything. As much as I'd like to have my say, I'm not going to. The one thing I did just want to say is that I actually viewed the Communities and Partnerships Committee this morning, and Susan might want to look at some of the stuff that was discussed there, because I think it covers exactly what she's just asked. Thank you very much, Chairman.
Thank you, Linda. That's great. And now the very last speaker is our City Council colleague, Anthony. Once again, you're very welcome.
Thank you, Chair, and thank you, Dr. Robin, for the report. I guess really, it would be remiss of me as the City Council representative just to ask that I can see that in Cambridge City there has been a slight uptick in cases. Looking back at the incidence level anyway, looking back at my other report circulated from Monday, it doesn't seem that there's been a care home outbreak or anything like that could obviously explain it. And as far as I can tell, Cambridge, with a high density of pubs, restaurants, workplaces, might be more vulnerable to the reopening up of society. And anecdotally, I agree with some of the other councillors that I think, in accordance with some of the guidelines, has certainly been a little bit worse. So I was just wondering, really, if we yet know really if this is something that's significant to be concerned about, or whether it's kind of just regression to the mean.
Today, I would say that it's fluctuating. So we haven't got evidence that that is an ongoing continued upward trend, because obviously I look at the figures every day. But I think you're quite right to say that there is potential for, given the nature of Cambridge, and that it is often in the towns and cities and areas where people are naturally closer together and where there's a lot of leisure facilities and social life. There are risks there. So we definitely need to keep a close eye on Cambridge, particularly perhaps when we get a potential when we get an influx of younger people coming back as students, as higher education reopens and things like that. There's lots of issues that we are looking at very carefully. So the current sort of uptick that you see on the figures that you have, I would say that is not today turning into a worrying increasing trend. It might change next week. We look at it every day. And we do absolutely, and this is true for all our districts and areas, we need to look at the risk factors for that area and do our communications and our interventions within that area to the right target groups and looking at the right issues. So the issues in Cambridge will be very different from the issues in Huntingdonshire, which will be different from the issues in Peterborough, and so on. So absolutely, we need to focus on some of those potential risk factors in the local area.
Thank you, Liz, and thanks for the question, Anthony. Are you happy with that? Or do you want to come back on it?
No, it sounds that makes sense to me. Thank you very much for the answer. It sounds like there's no need to get Cambridge United on the case quite yet. But
okay, my friend, thank you very much. So we was asked members to note the progress made to date in responding to the impact of the virus and note the public health response, which I do believe we have, and we've done it very well. So thank you very much. Can we move on now to item number 8, please, the agenda plan? Can I ask our Democratic Services expert, James, to introduce the plan, please?
Just to announce there have been no changes since publication. Thank you.
Thank you, James. Liz, Kate, are there any changes or updates you wish to suggest at the current time? No.
No.
Okay. Do any members have any suggestions which, if proposed, will be discussed further at the next chairman and lead member briefing? No, thank you. In that case, we are pleased to note the agenda plan and also note that the next meeting is on the 17th of September. That's the end of the agenda today. Therefore, I thank you all for your attendance. I will formally close the meeting. But once again, a big thank you to everybody. Thank you.
Thank you, Chair.